So control of intraoperative hemorrhage during vitreous surgery. The control starts right from the preoperative phase. One is, though these things look very minor, they can land you into major problem one of the days. So control of hypertension preoperatively as well as perioperatively, intraoperatively, everything is very important. To stop antiplatelet drugs, especially when you are expecting unexpected kind of bleeding in that part of highly vascular proliferations. It may not be there in a simple vitreous surgery, but where you expect that there is going to be extreme amount of bleeding in a highly vascular proliferations which you are dissecting, it's better to stop the antiplatelet drugs. And the minimum thing is at least 2 days for aspirin and preferably 1 week, both for aspirin and clopidogrel. If the patient is on dipyridamole, then you have to stop at least 2 weeks prior to the surgery. You have to realize that some patients have taking medicines with antiplatelet effects like NSAIDs, vitamin E, herbal medicines, all those things. You have to look into that history also. Patients who are on anticoagulants, you have to see that the INR is between 1.5 and 2. And sometimes patients who are on with bleeding diathesis, you may not have these bleeding clotting factors with you at hand. So the best thing is to give them fresh frozen plasma. It is not that you give them 1 day or 2 days earlier. It has to be given right before the surgery, because the half-life of some of the clotting factors itself is only 1 or 2 hours. So it's very important to give it right before the surgery, 1 or 2 hours before the surgery, and you have to give the right dose, because the dose is 10 ml per kg body weight. So you have to give at least be ready with 2 or 3 units of fresh frozen plasma, which are easily available with any of the blood bank. Preoperative Avastin is a very important step which we have to decide in most of the vascular proliferative retinopathies. The thing is that it is known to reduce the intraoperative, immediate postoperative as well as the recurrent postoperative bleeds in patients who are taking Avastin. It gives us easier and bloodless dissection of fibrovascular membranes. It also makes the fibrovascular membranes are actually detached from the surface of the retina. They become loose and it is easier to dissect them in patients who you are giving Avastin. There is reduced frequency of incidence of diathermy, number of iatrogenic breaks, and the reduced operative time. The thing is that you have to give it, it takes around at least 24 hours it takes to have a sufficient anti-angiogenic effect, but at least 3 to 5 days preoperatively we give as a rule. The other thing which you have to know is that you have to take the fitness of the patient and avoid postponing the surgery for more than 8 to 10 days, because the upregulation of CTGF which will cause a tractional detach. Anxiety relief of the patient. Many patients, though you are not anxious, the patients are very anxious. So anxiety relief, talking to the patient, good perioperative BP control. Patient is comfortably lying down, properly ventilated. You should do patients who are claustrophobic, you have to talk to them, and adequate anesthesia. This is very important during the surgery. Don't neglect these factors. Then choice of infusion fluid. Though commonly we use the BSS plus, it should be avoided because it contains citrate and which is known to have anticoagulant properties. Maybe even simple linger lactate or BSS plus would be preferred in cases where you are going to expect a high amount of bleeding during the surgery. There are reports of adding thrombin to the solution, but it has got a 10 to 20% incidence of sterile reactions after the surgery, TAS. So it comes with a disadvantage of its own. Have all the instrumentation ready with you, like PFCL, additional light source, bimanual surgery instrumentation, and sharp instrumentation which you want to require. You should not waste time during the surgery. You should be. So what are the intraoperative essentials which you should follow to prevent the bleeding? Pay attention to the bottle height. It should be adequate. Suppose for the previous surgery, the bottle height has been reduced and you forgot to maintain the bottle height during the next surgery, you can have problems. So ensure that the bottle height is at least 40 centimeters above the eye. Have additional infusion bottles ready. Keep an eye on the infusion bottle during the surgery. Sometimes nobody is paying attention to the surgeon is busy doing the surgery. Assistant is looking at the screen and the running person is also not looking at the infusion bottle. So you should avoid the episodes of hypotony. And then you can have a suprachoroidal or some other untoward problem. Suddenly the globe collapses. So prevent episodes of hypotony. Then routinely we do the PVD induction, but in case of vascular proliferative diabetic retinopathies or other vascular retinopathies, they have multiple pinpoint attachments of the posterior haloid. So you avoid the PVD induction. You have to go around these vascular proliferations and do a modified PVD induction, not a classical PVD induction which you do. Otherwise you will have lot of tears and a lot of hemorrhages going on. Ensure adequate visibility. Once you start dissecting the proliferations, you should adequate magnification, adequate visibility, wetting of the cornea and other things. Ensure that all these things are there before you actually start the dissection. And resort to bimanual surgery earlier than as a last resort. So the moment you have a look into the vitreous cavity, you will see that you will need bimanual dissection. You just go for it earlier than later. So, and the other thing is that you should know when to stop the dissection. Only the vascular proliferations which are exerting the traction on the disc and macula should be properly dissected. Others, you have to just trim it around and let the laser do the job. This is a video showing you there are large proliferation both nasal to the disc and one is having traction on the macula. So I am just releasing and the traction around dissecting the proliferation around the macula, and you can see that the one which is nasal to the disc I have just trimmed and left it around. So you can see at the end of the surgery that if you dissect that highly vascular proliferation which is not exerting any traction on the disc, you will increase the surgical time by half an hour. Similarly, you can see here there is a huge proliferation which I have dissected only the disc and macular area, and I have left the whole vascular proliferation which is nasal to the disc and around the arcade. So you can cut down on the surgical time. Don't peel the clotted. Once the bleeding occurs, it seals with the natural mechanism of clotting. But the moment you remove the clot, the bleeding starts again. So avoid peeling the blood clots unless it's actually covering the visual axis, because it will have a firm tamponading effect on the bleeders. When you want to plan doing the retinectomy, don't forget to do the diathermy of these vessels, because if you are in a hurry and start doing the retinectomy before doing the diathermy, you will have unnecessary intraoperative bleeding, which is an avoidable complication. Now, management of bleeding, there are some textbooks which classify this as minor bleeding. So you can just say that a small bleeding which stops on its own or with a simple raising of glottal head is called as a grade 1 bleeding. Grade 2 bleeding is it cannot be controlled by this and it needs diathermy. And grade 3 severe amount of bleeding which forms large blood clots around the macula and obscures the visual axis. Now what do you do once you actually have the bleeding? Once these are all prevention of bleeding. So the first thing is to observe. It's just a minor bleeding. You can just observe, raise the bottle head as we have seen in this particular video. And if it is not stopping with that and it's away from the macula and the disc, you can directly diathermize it. That is the best way to control the bleeding. So you can see that in spite of this thing, the bleeding had not stopped. So I allowed nature for the clotting time to occur. So you have to allow 10 to 20 minutes. I have completed the laser. I have relieved the traction, and you can see that the bleeding has stopped on its own. So doing the cautery of the bleeders which are not away, which are away from the disc and macula, and traction relief around that bleeder is also important. Now what happen? How do you take advantage of other methods of controlling the bleeding? Now disc bleeds are very common. One is that if you have a highly vascular proliferation on the disc, complete the whole surgery and try to do it towards the end, because I will tell you that the air is the best way to control the bleeding, and that you cannot do when you have done an incomplete vitrectomy. First is you see that you have done most of the surgery, and then you can maybe infuse the air at the end, which is the best way to control the bleeding. A simple bleeding will stop on its own. If you have a small bleeding which is there from the disc or the posterior pole, you can infuse around 1 or 2 ml of PFCL. Sometimes then you go on with your surgery, and if it is not getting controlled, then ultimately you will have to use air, which is the best way to control the bleeding. Now, doing the dissection in highly vascular proliferations or TRDs, you have to remember that you will have such a picture. But what you have to realize is that you have to use the diathermy and the backflush needle, and you have to control the bleeding. And air again here is the best way to control the bleeding. Now this is a case of combined retinal detachment and you will have lot of bleeding. That is expected. So what I am doing here is, I will not dislodge the blood clot from where the source of bleeding is there. I will just clear the blood around the macula, and I have left the blood clots which are the sources of the bleeder. And then do with the rest of the surgery. and then again at the end of the surgery I will infuse air and wait for 5 to 10 minutes, do the laser, and that is enough to control the bleeding. So what about silicone oil? Some patients, some people believe that if you just at the end of surgery inject silicone oil, everything will happen fine. It is not like that. Unless you have controlled the bleeding, you cannot infuse silicone oil in that patient, because you will have a late post-operative bleed, and that you may have to do a resurgery to remove the silicone oil and again control the bleeding. So one thing you have to remember is that the bleeding should have totally stopped before you have controlled before you injected the silicone oil. Sometimes if there is a small bleed in the post-operative period, that can get localized by a silicone oil, but if there is a uncontrolled bleeding, even the silicone oil cannot stop it. So these are the few points which I wanted to discuss. Thank you.